Well, welcome. I'm so glad and honored to be here again. This has been one of my ongoing projects for the last couple years. So I'm excited to show you our work, and let's get started. Next slide. So our learning objectives, what I really would like everyone to take away with this, we did this project specifically in MRI, but I would like you to know it can be applied to any radiology imaging area. Okay, so our agenda today we'll start out with our introductions and organizational overview, and then we're going to dig into the why and some objectives and our strategy and our outcomes, insights, and our future plans.
And I'll tell you a little bit about us here. So my name's Lauren. I'm Associate Director for Inpatient Imaging Services at OSU Wexner Medical Center. And
I'm Annette Long, and I am Inpatient Imaging Manager of the MRI services on UH and James at Ohio State.
Okay, so we've really partnered together on this project for the last few years now. And then additionally, we worked closely with our teams. It's really important to note here that our radiology analytics expert was key to this, as we had the appropriate data to use to implement changes and really work on it. You'll see other key team members, departments that we worked with, but really we couldn't do this without the MRI team itself. And so that's Annette's team managing. And so disclosure statement up here for you. And then I'll tell you a little about OSU. Sorry, I went too fast there. So we are Central Ohio's only academic medical center. You can see up there our stats with our 7 hospital staffed beds, a lot of employees, and 100+ facilities. We are a nationally ranked academic medical center. You can see there, again, we talk about our staffed beds. Patient admissions is on here. And we have a lot of faculty, outpatient visits, telehealth as well. And we have been ranked for 31 consecutive years by US News and World Report Best Hospitals. Again, we are a magnet institution as well, and so that's important to note there, as I am a nurse. And so our hospital tower is what's coming up in the next year for us, and it's scheduled to open in 2026. It is the largest single facilities project ever undertaken at Ohio State, and it's really important to note that there'll be 820 additional large private rooms. While we will close some within main house right now, we will be adding rooms as well. And let's talk about the why here. So there was an increase in MRI orders, and our current departmental performance needed optimized. And so this button is really click happy here. Looking here about why we optimized. So we were unable to meet our MRI demand. Demand was outpacing us in where we needed to go. And the aging population is resulting in increased MRI orders. Not something I need to tell any of you. You've seen it all within your space. So we have delays in cares. You can see the outcomes to our delays in cares. Big thing here is that it does lose revenue, which is top of the hospital, what they start looking at. And then also it increases the number of patients that complain, which again, that goes into your reporting and what the hospital looks like. But what we really go to is how many patients we weren't able to care for. And so how do we optimize our space to get to the why of how we care for those patients? So really working with projects, if you cannot measure it, you cannot improve it. And so we really live in this for every project we go into. How do we measure what we're doing even? So the first measurement we look at here is our growth in our enterprise-wide volume. And so this is enterprise-wide, where we talk about year-over-year comparison. You can see the growth where fiscal year 23 is on there, 24 and 25. That's your graph on the right-hand side. It's important for us to note this year-to-date growth shows we have completed 11.3% more MRI exams, and that's compared to the same time frame from last year. And the year-over-year shows that we've increased steadily each year for the past 2 years. Narrow it down a little bit. So I talked about enterprise. Now I'm going to talk about UH and James. That's Annette's control here, and I partner with her as the leader. And so what we're looking at here is that there's been a 10.4% growth in the same time frame. That's on the left-hand side. On the right-hand side, the year-over-year comparison again shows that we've steadily increased our volumes. Oh, I'm sorry, I didn't even switch slides, did I? I hope that came through there for you. Again, click happy here.
Okay.
Go ahead.
No, so okay, like the objectives, like what changes did we really need and how did we get there? Next slide. So starting out with a process map, a problem well defined is a problem half solved. This kind of resonates with me because you first need to figure out what the problem actually is before you can implement and solve it. So in this diagram, something I'd really like to call out is there's areas of opportunity where all the red stars are. And looking at all of our interdisciplinary teams, we identified that this is areas that we could really make and implement change. And so we started out and we did a lot of different measurements, and we were in the improve phase here. So we're taking a look and we're doing a swim lane, we're doing a fishbone diagram, and really just focusing on what maps, what we can do, process identifiers to actually start this change. And then our key driver diagram, we kind of broke it down into different work groups and began the process.
What I really like about this is using the DMAIC framework really helps us to strategize on how we focus on what, right? You don't want to boil the ocean. So what Annette's done a really good job with is utilizing these tools in her space to make sure they are working on the things that actually need improved and not just trying to boil the ocean, trying to do all the work at once. So sorry, I wanted to highlight that for you, Annette.
Thank you. And then we identified some key attributing factors. And so with all of these tools that we used, we discovered areas of opportunity. And so strategy, like how did we execute it? What did we do for change and how to improve it?
Yeah. I like to go into Edward Deming, his lens of profound knowledge. And so this is any QI work you go into here. So quality improvement is very important. This gives you a framework on how you think about quality improvement. So it's appreciation of the system and that variation, the human behavior there, and also the theory of knowledge. And so what knowledge is within your space as you implement quality improvement change. I did put a link on here as well. So if you wanted to look at the IHI's website for the science of improvement, that helps you get started on QI work. So then we go into our strategy for implementing the change, and this is big. We start with the culture. If you notice that is the first thing on here, that's because if you cannot work on your culture and cannot improve that, there's really no work that can be done. So you ensure your team has the right resources. Again, that's part of your culture work. What is your team identifying that's the problem? Then we strengthened our interdisciplinary partners. Who are we working with that really isn't working with us? And so how do we work on that? I said work like 3 times in there. We established our baseline performance. We swiftly implemented our quick wins. That's the low-hanging fruit, optimized technology, and then provided follow-up and maintain team engagement. And so looking here at the culture of the department, again, I said that's where we focus. And you seek first to understand, then to be understood. So what purpose does the team have? What processes are in place to really support this team or not in place? How do the people impact the culture? What do you have a lot of, is there a lot of positive energy, negative energy? How do they impact the department? Identifying hidden leaders and leveraging networking, engaging the team for their feedback and buy-in, and then providing structure and accountability. Then going into the team having the right resources. So we really don't want to do more with less. We want to do better with the resources we have in place. And that's what process in place, again, that doesn't support your teams. Does the team and department have the right tools? So what tools do you need to give to them to grow, to do the right thing, to engage your department and to improve? What ideas are barriers? That is a goldmine of information, anything that comes from your team. We often think it happens where we'll say, oh, we have an idea, but really what ideas do your team have that you can really pull from them, because they're the ones that do the work day in and day out. And then can technology be utilized to support the teams? We're all about automation. What can we do quicker, better, that doesn't make our teams have to work harder?
Okay, and then this slide, providing the resources. What resources do we really need? And here's a couple examples of some things that we did. The implementation of a standard triage algorithm, being able to prioritize care for stat and ER orders, and care for our patients oldest to newest, partnering with our radiologist and helping them work with our life, escalation, our life threat scans. And then identifying staffing, bringing more staffing in, bringing different types of staffing in. So we've added, in addition to what, our technologists, we now have PCAs in our department. We have nursing within our footprint, implant specialists, and students. And then just most recently, we purchased a Pyxis, identifying areas of opportunity for delays in patient care when patients need medication. In order for us to get here, I attached, this is a Kanban board, and really engaging the team members in to be able to put changes or things that might help turn around time in a safe space as they walk to their break room. they could put a post-it note of something that maybe they thought could help patient care. So very important. And this is where we established our baseline. Next slide, please. And so looking at our current landscape, how did we get where we are? And so with looking at this process map and mapping in our current performance, like what we need. So
something important here is the PDSA cycle work. And so looking at plan, do, study, act, right? It seems pretty simple, but then you have to keep reevaluating this. And so that's why we are on the third iteration of this project.
Next slide, please. So swiftly implementing the quick wins. So it's very important to really highlight that short-term wins provide proof that we change incentives are making progress. No one wants to like go into a ball game and not do something really great and feel good. So us being able to tackle like low-hanging fruit, things that we've seen that cause delays, and continuing to create the buy-in and motivation, it starts inspiring people to give more ideas and to move forward more rapidly. Next slide.
This is really where we talk about the technology optimization piece. This is huge to our success here. And so we have an AI-powered technology. It's available that accelerates our MRI sequences. This whole slide deck is not going to go into too many details about it, but this shows the timeline here. And that in March of 23, we had a new technology trial. That trial showed success. And so 11/23, we initiated protocol changes. In that, we distributed, it didn't transfer there, the protocols on the scanner, and it resulted in an average of 40% reduction in scan time. What I want to call out here, this is just looking at knees alone. And so knees are bread and butter in MRI, right, Annette? And so really one of the most common with MSK back in the day, it used to take about 30 minutes to do a knee, talk a lot about that. But really you can see on the left here, it took us 17 minutes and 38 seconds. That was without using our AI technology. And then moving to the right there and move it down to 6 minutes and 46 seconds. And so then you could get 2 done in the time it took to do 1. And so again, move to the right of the screen here, real data from one of our scanners. So I can show you on the left what it looks like, but really on the right shows real data that demonstrates here the last 6 months. We show an average of 8.31, and the other scanner cannot be optimized with AI technology. And so it shows a 21:39, and you can see change time there as well.
And this was one of our, this was one of our quick wins. This is something that once it was implemented and once it was looked at, we realized that this was a very quick win for our department. And so what do we need to do? Strengthen the interdisciplinary partnerships. Who are the stakeholders? Making sure that everyone is included in looking at the process, and engaging different teams, engaging nursing, engaging transport. So it's very important when you start a project to make sure you have the right people involved. Next slide, please. And then the providing the follow-up and maintaining team engagement. With our teams and with the teams that were involved, having the monthly meetings, talking about our successes, talking about our areas of opportunity, and then continuing, and I keep going back to this, continuing to strengthen our interdepartmental relationships, making sure that everyone, is at the table and everyone has a voice in order to assist with helping take care of our patients. Next slide. And then team engagement efforts. So some of the things that we did with the team, that I did with the team, and I still continue to do with the team, is having, the Kanban boards, the daily huddles, constant follow-up, and constant efforts to really, celebrating our successes. And it's very important when there's visual boards, like the documentation of our inpatient queue. One really quick thing I'm going to call out is July of last year, I went on vacation. There was 150 inpatients waiting for us to be served. When I left to come here, there were 23. So we had a board and everyone documented what the queue was in the morning and what the queue was in the afternoon. And so once we started implementing certain changes within our department, they started to see those numbers go down. And that's, for some technologists, that's like, wow, we walked in, there's 19 patients. versus, wow, we walked in, there's 140 patients. So I just wanted to call that out because that was something that I heard a lot of positive feedback on. Next slide.
Yeah, I want to pause real quick too here, because Annette, she just pointed out something that's so big. With that 150 queue, the technologists were coming in and we're feeling so much pressure. They couldn't even prioritize or strategize on how they're going to take care of their day. Instead, they're just pooled. And so with tracking that and making some of these changes and getting that number down, it's helped them to make sure they're taking care of the right patient at the right time.
So moving into outcomes.
Yeah, and so I'm going to talk about our outcomes, and we're going to spend a little bit of time here looking at it. And so I mentioned that we work closely with in our engagement session earlier, that we work closely with our analytics team, our ACE team, and then also we have somebody who works in the data with us within our department. And so looking here, this is a control chart, and so data is pulled from Tableau, which feeds over DICOM data, and also Epic feeds into Tableau here. And so we're looking at routine, median, order, begin time. This is a control chart. We do not have 12 data points below, so we could not shift our center line fully. And I say we do not have it, but we do not have it in this iteration of the project. When we previously presented, and it was over a year ago, we were able to shift our center line at that point. And so previously it was even at around 36 minutes for routine turnaround time. And so you can see up there that we have decreased, continue to decrease, and we are maintaining below, and that we have confirmed a shift, but that we are not able to change it until we've gotten to 12 data points. I'm going to move to our stat turnaround times. Again, with stat turnaround time here, in 4 more months, we will be able to change our upper control limit, lower control limit, and then our center line. If you're not familiar with control charts, happy to talk through them a little bit more here. But really, this just tells you, are you in control of your system? Do you know what you have in place? Are you able to say, I'm making the right changes at the right time, and I'm going to decrease it? And this really helps to show you what kind of work we are doing. And so we've been able to sustain and maintain that work. This next slide here is we switched our goals a little bit in this project. So we started measuring the percent of the patients that were actually meeting our turnaround time goal. So our turnaround time goal is a benchmark that is set internally for us. It was utilized with data many years ago, and we've been talking about assessing it and changing it. And so I got a smirk from somebody on my team here who works behind me, because this is something that we often talk about. Our turnaround time doesn't serve us well. There's not good data out there. And so how do we generate that evidence there to show what's the appropriate turnaround time? But we are benchmarking ourselves with our turnaround time. And you can see where we started implementing changes in May. That is the red line. And then up above shows the percent. And so you want to be moving upward, percent of routine patients that are meeting the turnaround time goal. This is a lag metric, so it's not something we're going to look at daily to say, are we sustaining this? This is going to follow the work that we do, where our other two were our leading metrics. We're going to go into our volume increase. So this speaks volumes. So our patient technical volume increased 282 exams. So that's a 15% increase from December 24 to December 25. We could blow this graph up and look daily, and you can see it there too. But we've maintained our current volume while improving our turnaround time. We have increased resources. So people will say, well, you got more people in the department. Are you making revenue? Yes, it's MRI. So you're still making revenue with adding those people in. But you can see there that 282 increase would be significant in our department. This is just, again, the inpatient setting. And so implementing changes in the outpatient will have a good ROI as well.
So reflections and takeaway.
Yeah, and we'll take our time on this part too for you.
So I was going to say, next slide.
Oh, yeah.
So be the best at getting better. One of our executive leaders, Dennis Delisle, said this, and once again, it really resonates with me, because we just don't want to stop because we've met our goals, or we have met the goals of the enterprise scorecard. We want to continue to optimize and continue to be the best at getting better and taking care of our patients. Like, we're here for the patients. So I really, like I said, I really love that quote, because we're not going to stop. Like I said, once we hit our goals, we're not going to stop. So we just want to continue to see what improvements we have and continue to change. And so some of the lesson learned, not everybody in our department, not everybody within my department saw the changes that we made as positive. But we definitely have to engage the people that are not, maybe they don't like an idea, or maybe they don't feel comfortable speaking out. So one of my employees is definitely a naysayer. And when I actually sat down with him and we talked, he was able to tell me why that things that he felt like, the changes were a lot. And so I actually engaged him, and he created a standard work optimization for when we call on an inpatient, we optimize everything that we say to the nursing staff, and everyone does the same thing. So if you're looking to call a patient down, you can see if the patient's ready, the questions have been asked, and that's just a copy and paste on every patient. So the work list looks the same for everybody. And I engaged him, and he did a PowerPoint presentation on it on our staff meeting, and he began to train people. So it's very important, even the people that you might not think have anything value added, they could actually just be hiding it. So you got to get in there and get it. And then, like I said, evidence should drive changes. Look at what other practices are doing. Look at what has worked previously. Look at what hasn't, and base your evidence off of that. And I'm going to say this, and this is kind of funny, but when one of the big changes that happened in our department was we have nursing in our footprint now, but just not only nursing, but we have nursing in leadership positions. And so they have different ways, evidence-based practice, that they do things, which they've brought to the table. Because believe me, I did not want a nurse running my department, but Lauren is a nurse by trade. And this was
she's used to me by now.
Yeah,
guys,
this was something big. And so, but listening to everyone. So I had to say that because it was a challenge in radiology.
That's true.
So, and stay in the praise. So, sometimes things don't work out as well as they should, but the little small wins, the quick wins, always make sure that you're giving praise. If you come to me with an idea, I'm listening. But also when something works, recognizing the people involved.
Something I want to say on this too, one, the evidence piece, she's right. So in nursing, we do look at different than our technologists. And so what's been wonderful is the partnership we've had, where I would miss big pieces and not be able to even support her department without her work in it. And so it's really good. It's a really good relationship and good partnership with all of my managers who are technologists and work beside me. And so she's right. It was not always received well. And as we move nursing to help and support in our department, that was also hard for the department at first to understand that they're working with us, not against.
And like I said, I'm going to piggyback off of this idea, and we won't kind of get in the weeds with this, but we also have a quality associate director, and she's also a nurse, and she has taught me so much. She's brought so much to the plate, and it's been very nice to see that different world and stuff that I never would have thought. So,
and that's how we got our quality branch too within our department. And so that was a huge piece, as we have quality leads. So when we were talking about technology optimization, he is one of the people that would have presented with us that talked about the work that is done within it and how important his role, and it could be her in another area, ultrasound or CT, but how important that role is and that quality arm is to making the changes. The other piece I want to pull in here is you talked about that not everyone would see the changes as positive. There was a time when we were talking about our team helping with pushing and pulling patients to and from the floor, because we all know transportation is a delay, and that was our first project, was partnering with transportation. But something we really looked at here is one of the team members said to me, the words were, if I start pulling the patients down, everyone's going to expect it. And so that's a valid feeling they have, right? However, it was a discussion to say messaging and how we are all helping and how every single person has a job to do, and it's a nobody's job, so therefore it's everybody's job. And so Annette has really done a good job encouraging the team to not be a naysayer and instead say, how can I influence others to want to transport my patients, to want to help with the work that is a nobody's job.
And this is another thing, when the culture starts to change, there's different attitudes and there's different views, but there is any given day that I walk down the hallway from my office and I can see anyone ranging from one of our nurses within our department to one of our PCAs to a technologist. taking and caring for patients. And now it's almost like second nature. When someone needs to go back and transport's delayed, then they just jump up and do it. And that's also trackable data too. We put in that we cancel transport, but we have somebody taking the patient back to the floor. So I'm very proud of the team.
Yeah. Yes, our transport does have its own union as well. Is that at your hospital as well? Yeah, we can. It does. Our nurses are unionized as well within our hospital, not in leadership, but below leadership. And then additionally, we have another union for our PCAs. So Annette could be managing 3 different unions if she had her own transport. She doesn't, so she has 2 different unions. But it does make it trickier. And so, yeah, save that thought and come back to it, and we'll talk about that more for sure.
Next slide.
Yes, ma'am.
So if you don't take anything away from anything that I've said all day, always remember, once again, a little bit of history. When I stepped into my role about 5 years ago as the MRI supervisor, then manager, OSU, that department hadn't changed in so many years. Change was not a thing there. And so the team didn't always feel safe to speak up. So always, I found the engagement part and having team buy-in is so incredibly important for not only for a project to succeed, because we might want a project to succeed, absolutely, but we also want people to feel comfortable and people to feel safe to speak up, and that's where the culture starts to change. So we still, like the last staff meeting, I still went over where we are in our project. I always ask for suggestions. I mean, my door's always open, or they can email me, give me a Post-it note, because a lot of the team members now they just openly shout out things, but it's really funny, and it's okay. Like, I like that. So, and that's where it comes to validating, even if you don't think it's a good idea, validating that they've made the statement and we can look into it. And also, once again, make sure you have the right team and members involved in the project work. So you want people that are also the same way, like they want to listen, they want to work very hard, and just making sure that if something doesn't work, communicate where you are within the project. What are our next steps? What are we doing? And it's very important, once you get there and we get low-hanging fruit, we get these quick wins, we celebrate as a team. And that word is not to be used. We don't ever want to fail. There are areas of opportunity, and maybe something doesn't work, but maybe we can look at it and fix it and make it a better way, because honestly, you have to not succeed sometimes in order to succeed, if that makes sense. And then patience. I'm as patient as a saint, because I've been working on this project for now 3 years. And so, and let me tell you, I can't tell you how many times when I stepped into my role, I mean, it was a crisis. I mean, think about it, over 100 people waiting for an MRI, and still trying to service a small outpatient population, because within my footprint, we do all the anesthesias, we do all the pacemakers, we do all the non-conditional devices, and we pull from so many different resources. So being patient and knowing that things will not change overnight, but they will continue to change if you continue to pursue them.
Yeah. I think something big with this too, you mentioned how you engaged the team and how she created that safe space. That was that Kanban board, because coming in to the department, I've been in the department for 2 years, nobody would really talk to me. And so I came in and was like very open to talking, she would, but not her team. And so it was how do we get her team to engage? And so really talking about like, how could we get their buy-in? How can we get their engagement? How do we get their partnership? And so that is where the Kanban board came in and the sticky notes. And then it started talking about, okay, well, why is this possible? Why is this not possible? Maybe this is a parking lot. Maybe we need to consider something else. And you made that safe space for your team to speak up, and now they do openly.
And something that everyone in the room doesn't know, except maybe 2 people, but we were very siloed within our Department of Radiology. Up until last June, we never had nursing in our footprint. We have 2 nurses now within the department. but there wasn't really a lot of collaboration. So Lauren coming in as a nurse and, our quality associate director coming in as a nurse, it was kind of like, oh, nursing. And so definitely making sure and creating that safe space to know that they can, if they have changes or they want something changed. And it's funny now, I mean, they're just as comfortable coming to Lauren as they are me. So
now I'm telling Annette, your team came to me about XYZ. How would you like me to approach this? So it's been really good. I am going to talk now. Again, change happens with and through people, not at and to them. So you're not changing a process, you are changing with the people and through them. And so first who and then what. And so if you've noticed the whole time we've talked about who we would engage first and then what we would do about it, because that's been the key to our success the entire time. It is never a what are we going to do and who do we pull in. It's a who do we need to work with first. So here are key reminders along our 2-year journey. So big thing here is that continuous improvement is a journey, not a destination. And so how Annette said that, this has been patience, persistence, it's needed as we move forward, we are continuing to do it. So Lean Six Sigma is about constant iteration, constant tweaks, changing in your system, finding out what your measures are, and then what your countermeasures do to your system, and then what do you do from there, has been important for us. And so continuous improvement. That data-driven decisions lead to better outcomes. And so we talked a lot about the who we'd engage, how we would work with them, but you do have to have the data there. We can't say it's just a feeling. We all have those feelings. They're all probably very valid. And so part of my work with Annette here is finding out what data she can use to build her case for business as we move forward. Engagement from all levels. So we kind of talked about this, that you need everyone involved. You need to have the right people at the seat here, but really you also need to make sure you're engaging the different levels of your organization. Do you have your C-suite level support? Do you have your management leadership level support in your department? What about your team members below you? What about the people that work beside your department, under your department, the people that aren't thought about? Transport's one that is pushed to the side often, but how crucial were they to our first iteration of the project? And really change management is important as process improvement. And so we talk about the PI work we do here, but really it's a lot of change management work too, because without that, we would not be able to implement the process improvement changes. I put here focus on sustainable results, but really it's focus on the results that you can actually change too, because yes, they need to be sustainable things, but it also should be something that you can have an impact on, right? And that goes also to what data you're using to drive your decision. And so the measuring of the right metrics. And so clear and relevant metrics that are important to your department will help drive you forward. And so really looking at aligning your metrics with business goals to ensure that you have the right work in front of you. Go ahead. Oh, I got this one too. I'm so sorry. So really looking at, again, first who, then what. Our efforts will be dedicated to continuous improvement of this department. And so we presented last year, we were working on the project for the year before that. Our path to success is going to start coming from a different direction here. So we put on here that we need ordering provider ownership, nursing engagement, and anesthesiology partnership. The order provider and ownership is very huge to us because our C-suite will ask us, well, why aren't you changing the amount of stat orders coming in your system? That's a great question. How much control do we have over our stat orders coming in our system? What can we do to actually impact that? And so that's looking at and working with an ordering provider that will be a champion in our organization. It's a huge organization. And so somebody with a big voice that has a big impact that can actually make the change needed to drive how ordering physicians decide a stat order versus a routine order. It is not something I could walk in a room and say, that's not stat. I'm not the one caring for that patient. And so we do have a team that is working on 3 different projects on ordering provider ownership. One of them is within the ED, and she is very vocal and working on, I believe it's back. Is that correct? And that she's working on back MRIs, spine, something with ortho.
Yes.
Yeah, and so that's a very new project to us, and we are actually not the owners of that project, even though it is her space. And so that was hard at first for us to say, well, how do we not own something that impacts us so much? It's not our place to own it, but it is our place to drive it and be supportive of her, just like she has been supportive or they have been supportive of us. So that will be key as we move forward with the different projects with provider ownership. Another piece here, nursing engagement. And so that's on the floor. And that is working very closely with our nursing team and our new collaboration to make sure that we can have our nurses build into their brain a pre-screening form. And I say brain because we have Epic. And so nursing has a brain that they can see when they open it up, and that drives the work they do in the day. And so putting in, if they have an MRI, a pre-screening form will show up for them to complete. Oh, sorry, go ahead.
Quick question.
Yeah.
So you said you're a teaching facility.
Mm-hmm.
One of our challenges is that we have fellows and residents that are ordering willy-nilly,
Correct.
and we have to zone them in into reality. And we've designed some of, like a protocol as to what nursing, and I tell my nursing staff, you need to question them.
Mhm.
They are learning, we are their guides,
Mhm.
and it's okay to question them. So how did you handle those challenges as far as like the ordering provider? Because obviously the attending is the one signing off on it,
Mhm.
but it's still these residents,
Residents.
fellows putting in these orders, and they're kind of like, what are you doing?
Yeah.
What did you do?
So that's huge. First, I can't tell that ordering provider or resident that they're wrong, essentially, but I can guide them. Nursing is taught in school. We are taught that we are to question. You're the last line of defense before the patient is cared for. You're the last one with your hands on the patient, so you're responsible. So if a physician says give X, Y, Z, and I don't feel comfortable for whatever reason, I'm going to speak up and stand on that. And so that is, nursing does do that with exams. We often step out of bounds by doing that. If you think about it, I have a physician telling me to perform an exam and I say, no, I'm not comfortable with that. And so it's a very touchy, and it's hard to navigate. It is something to the core of myself as a nurse, and our teams are taught and our technologists are taught that we can question, like, is this appropriate? But it is not a saying we are not going to do it. Instead, our technologists will lean on the radiologist to make that decision. And so we have that with an MRI, every area I have.
We are very fortunate because we have huge support from the radiologist.
Mm-hmm.
I mean, our technologists, they'll look at an order and this is wrong. And so if they will call the RAD, and then the RAD will, they'll either re-protocol it or have the technologist get in touch with the ordering provider. But I will say my team does an amazing job. If they entered all the good catches that they might have, like every single day they are changing something or fixing patient orders.
Mm-hmm.
And we've also had a lot of, I'm just talking about collaboration. Neuro, we've had a lot of collaboration with. So the new residents that are coming in, the fellows, they're educating them. And I will say this is not really, we did gimbal walks within their space, and we listened to what barriers they had. And I remember one day I was in neurology and they said, oh, well, we put in an order for a complete spine and a brain because we're not actually sure. What we really want is a lumbar spine for cord compression, but then it takes so long to get an MRI. And so
Mm-hmm.
but this was in the very beginning, like that, and I listened. I mean, of course I don't want to hear that, or I put this MRI order of the brain in because I know your team is not going to get to it for 3 more days.
Mm-hmm.
So that's when I really want it. And so these are the kind of things, but we have a physician champion. Actually, the project, this MRI access optimization project that I'm currently the lead of, we do have a neuro physician champion that supports me, along with a radiologist champion. So, and it's hard. Like I said, you don't always want to hear the feedback of your department, like, well, we just order whatever because we can't get a hold of a radiologist or we don't know how. And so these are the things that you take to a team and you let them speak freely and then start working on, well, how can we improve this?
And I think what's really big is you're also asking about the ordering provider and how they order in the nurse's bedside and questioning or should question. I'm going to be very transparent and very honest. When I was bedside, if a physician ordered an MRI of whatever it was, I did not look into if it was stat, routine, urgent, whatever your priority system is, because that was not, I want to say not my job, but also not my knowledge base. I wouldn't know as a nurse what is appropriate for what kind of scan and which part of the body. Taught very different schooling. And so that's where it comes into partnership here, because Annette's team, so the nurse doesn't do the stop, but the Annette's team does and gets the radiologist to be the one to do the stop there. And so that's where we come into, okay, what can we control? We can control that her team can say, this doesn't feel appropriate. I'm getting the radiologist who is actually my person to do it. I can't control the nursing that's outside of our department, but then we can help partner with the ordering provider team. And so we're looking at one of the teams, many, and they have residents under them too. And so making sure that they are the ones responsible for analyzing the how many were misappropriately ordered and what did you do about it. And so I would, if I was to give a suggestion, say start with what's within your scope, not what other teams should be doing. And so that would be your team, and then what would be the best partner, and the ordering providers are the way to go. They're the ones that have the voice for the change. So that project is ongoing and newer. It initially was our goal when we started this project 2 years ago. We wanted to implement changes to help affect ordering provider practices. It was not an attainable goal. And so then we changed to what's within our scope.
And that was funny that you say that, because that's where within the slides, some of the first slides, the key driver diagram, we realized within our project that it was a lot.
Yeah.
Like it was it wasn't out of scope, but we needed to break it down. And so we broke it down into 4 work groups originally. And then we decided we need to actually split off and have champions and black belts in each of these projects, so that the ordering provider project was one of them that we're talking about. And so future plans for us, establish a demonstratable business case for quality, and create in-house held time slots for specific outpatient scans. I do want to call out on this. We also identified, as we are breaking everything down and looking at our MRI schedule, there were areas of opportunity, and maybe transport, well, let's not use that. Maybe the areas of opportunity where nursing has to give a handoff at 7:30 p.m. or 6 to 7 p.m. So nurses cannot travel with their patients on tele. They can't get their patients ready because they're giving handoffs. So creating time slots, we went in and optimized our scheduling template, and we put outpatients in these time slots. Ideally, what we wanted in an inpatient base, like within the hospital, is we first wanted to service our inpatients, but then also be able to service our outpatients. And so we did that and continued to maintain our turnaround times. But like I said, we were looking for areas of opportunity that maybe we weren't not being productive, but maybe we just weren't able to get the patient down. And then enhanced inpatient staffing model to support expanded hours of operation. So painting a picture for executive leadership, I can come up to someone and say, hey, I need 5 more people. And they're going to ask me, what data do you have? Like, what can you do for me? Why would I give you 5 more employees? And so really focusing on, okay, with this many staff members, I can open to 24 hours a day, 7 days a week in one area, every day, 3 scanners. And so I've been very blessed to have staffing and to be able to hire more people within our department. And then this implementing the nursing pre-screening, this was something that in my goal, in my mind, and all of the suggestions that came, I wanted this to be the patient's first initial screening. But it was also, there was barriers because the nurses had to go through 5 different screens or 6 different screens and then make sure they found the MRI. It's called the flow sheet. And then it was difficult. And so there's a lot of waste. If you're a nurse and you're taking care of a patient, you don't want to jump like 5 different screens. So having it actually, when the MRI is ordered, assigned to a task, current state, a task in the brain, but current state, I didn't want to make it a hard stop because it's not something that I want to go that battle with and say, you have to do this, but more working with collaboration and education and making it something that the nursing staff would want to do because it's best care for the patient. If you get the screening form done, then we can get the MRI done faster.
She's blessed with a counterpart within the nurse manager realm that is working closely to help with implementing these changes. So that is all we have. We wanted to leave time for questions.